Good morning, everyone. I'll call this meeting to order. Mr. Casey could not be here today for personal reasons, so there's a new sheriff in town. Just joking. Welcome to meeting number 41 of the House of Commons Standing Committee on Health. Today we'll meet for 2 hours with witnesses on our study of children's health. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. I'd like to make a few comments for the benefits of the witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either floor, English, or French. For those of you in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. Additionally, screenshots or taking photos of your screen is not permitted. The proceedings will be made available via the House of Commons website. In accordance with our routine motion, I am informing the committee that all witnesses have completed the required connection tests in advance of the meeting. Before I begin, I'd like to advise members that the topic of today's meeting is childhood mental health. Some of the discussions may be difficult for viewers, members, or staff. If you feel distressed or if you need help, please consult the clerk for information on supports available through the House administration. One other housekeeping item before we get going. I will hold up a 1-minute sign when you have 1 minute left, just so you know, help keep us on track a little bit. And hopefully that'll be helpful. That way we'll avoid cutting people off mid-sentence. That being said, I will now welcome the witnesses who are with us here this morning. Dr. Tyler Black, Clinical Assistant Professor, University of British Columbia by video conference, and Ms. Wendy Degou, Psychologist, also by video conference. Thank you both for taking the time to appear today. Each witness has up to 5 minutes for an opening statement. And Dr. Black, you'll go first. Just a quick comment. If you could unblur your background, there are some technical difficulties. I know that's been brought to your attention, and if not, we fully understand that. That being said, I invite Dr. Black to begin. You now have the floor for 5 minutes.
I thank the chair and the members of the committee for the honor of the invitation of this opportunity. As an introduction, I'm a clinical assistant professor and subspecialist child and adolescent psychiatrist. I've been in practice for 14 years. I was a medical director for a major psychiatric emergency unit for BC Children's Hospital for over 10 years. You've already met my colleague, Dr. Quinn Doan, an emergency physician with whom I co-created the Hearts Map, a psychosocial screening tool for youth. I'm also the creator of the ASARI, a leading practice tool for the completion of suicide risk documentation. I'm passionate about teaching, suicidology, mental health research, but most of all, I'm extremely committed to the health and well-being for the over 10,000 child and adolescent patients that I've seen in emergency settings and the child and adolescents that I'll never get a chance to see. Though my opening statement will not focus on these, I have submitted a briefing note for your consideration. Instead of drowning this committee with more wordy words, I've chosen to deliver graphs that demonstrate important data-driven perspectives that I consider to be crucial and neglected knowledge. I've also included 5 graphs to demonstrate the complexity of the data we are seeing in Canada for youth with mental health changes since the pandemic. As a quick aside, I never imagined that my experience in suicidology would lead me to be mired in political battles. But during the pandemic, my advocacy has led me to correctly cautioning against the proclamations of increasing rates of suicide due to the pandemic. In fact, they have decreased. I have been in public responding to the horrific use of children's mental health and suicide by politicians and non-mental health experts to justify resisting protections against a pandemic that has killed millions and has created over 10 million orphans worldwide. I have published and will publish more data that challenges the dominant moral panic narrative that there have only been mental health deteriorations in youth. Some youth have thrived, and we need to understand why that is. To the larger issue of mental health, my clinical work involves assessing children in the emergency department for mental health complaints and consulting with colleagues across BC. The impacts of lack of service are readily apparent to me. A significant percentage of my patients and their families are waitlisted for mental health services at the moment that I'm seeing them, leaving me only with the daunting option of calling to advocate for expediency or telling these suffering youth to keep waiting. Children who present to mental health teams across Canada are rejected for service due to exclusion criteria or put on tremendous wait lists because it's not severe enough, only later to present to me with a suicide attempt after months of unaddressed suffering. I deal disproportionately with youth in government custodial care or Indigenous youth in Canada, knowing full well that the systemic barriers, racism, and colonization are the reason that I see this disproportionate amount. The moral injury I suffer on a regular basis is incredible. I'm just glad to be the type of person who works hard during hardship, works hard to do my best during adversity, because if I were to stop and just survey the bleakness of some of the things that I see, it might just crush me. There are many things I think the federal government could do to improve mental health care and outcomes for children, and a non-comprehensive list would include improving the social determinants of health like poverty, abuse, education, and systemic barriers, ensuring the highest quality of care to minoritized, underprivileged, and children living in remote areas, cost-free access for families to pharmaceuticals and therapies, eliminating exclusion criteria from youth services, which only further systemic discrimination, ensuring federal support with youth with disabilities for all neurodiversities, ensuring federal standards for early access and timely access to care, money to provinces with agreement to create treatment centers with day treatment, step up, step down, and neurodiversity focuses, creating standards for school safety and establishing science-supported ways to make school less stressful for children. Psychiatrists are trained in a biopsychosocial model, and from day one, we're taught the importance of the social determinants of health. Frustratingly, I have few ways to prescribe or modify the social determinants of health to provide programs that would deliver services to youth that need it, or to affect on a large scale the effects of colonization on Indigenous youth. But the government does have those powers. On behalf of the children that I work with and the families and caregivers that love them, for all the youth I don't get a chance to see, I'm so grateful for that this committee is tackling this issue, and I really hope that serious and substantive change will come from the fruit of these labors. Thank you.
Thank you very much, Dr. Black. Appreciate that. I now invite Ms. Degout to begin. You now have the floor for 5 minutes.
Good morning, and thank you for inviting me to speak to you. My name is Wendy Degout, and I'm a psychologist based out of Antigonish. I work in my own private practice in Nova Scotia and in rural Nova Scotia, and I'm also an associate with Hexagon Psychology. Working in private practice, but also having experience in the past working in both the school systems and mental health hospital settings, I think provides me with a unique perspective around children's mental health. However, trying to synthesize my thoughts on children's mental health into 5 minutes has been daunting. The most obvious themes, however, when I think about children's mental health in Canada is around the gaps in service and ensuring that we keep in mind that in looking at children's mental health, we are also looking at families. So accessibility, we all know, is a huge issue. Wait times in Nova Scotia are very significant. According to the Nova Scotia Health Wait Times website, 50% of all non-urgent child and youth mental health referrals can be wait up to 77 days from referral to first actual treatment. That's actually the average for 50%. And there are many others who creep into several months. So if we're lucky enough to have financial resources and can either pay per visit or have health insurance, many folks will look at a private practice therapist for as an option. But thanks to the Association of Psychologists and the data they gathered in 2021, we know that the wait lists for private therapists are even growing just as much. So of the private practice psychologists in Nova Scotia who keep a wait list, almost half have a wait list of 2 to 5 months, and a further 35% have a wait list of 6 months to a year. So this is in the private system. Living in rural areas, there are also functional issues regarding accessibility. So our local district health authority covers a large area from Cape Breton to Antigonish. Our regional hospital covers 4 counties. some people have to drive up to an hour and a half to get to the regional hospital for mental health services. That means a day off work, having to get childcare for your other kids, and gas money, which is substantive these days. And although virtual services have been very helpful in allowing access during COVID, we still have issues of cross-jurisdictional practices boundaries between provinces, so this can cause accessibility issues. So if you have access to a nationally based EAP or to a private practice like Hexagon Psychology, you can only work with the people who are registered in your province. So nationally based referral programs are becoming more and more common in the last few years. So I think looking at cross-jurisdictional access is going to be more and more important. So in addition, many rural communities do not have consistent access to cell service or high-speed internet. For example, people 10 minutes away from our university do not have access to cell service, and many do not have access to high-speed internet. This makes virtual appointments not an option. So there's many other issues I'd like to talk about, but I don't have time. The need for culturally responsive and appropriate services, the gaps in inpatient services for children, the gaps in general for children aged 16 to 19, issues of food scarcity, homelessness, unsafe homes, underserved populations, the effects of COVID. But I want to spend my last minute or so talking about some potential solutions. I feel that we really need a collaborative approach, which allows for the integration of services where family doctors, therapists, psychiatrists, OTs, nutritionists, and other specialists can work together to support families. We also need to, I think, create a community-based case manager approach. We need someone who gets to know the family as a unit and their needs and can help them navigate through the system. We have some good examples of like our cancer care navigators and our Schools Plus models here. So I think we also need to look at bringing a regulated private practice professionals into a billing program such as the MSI billing program for doctors, and we need to look at cross-jurisdictional practice services. So in summary, I would like to ask that this committee continue to be creative in seeking a framework that can create equitable, accessible, and timely mental health care for children and youth and their families in Canada that allows for flexibility, that the strengths of communities can be utilized and areas of need addressed. And please remember, when we're dealing with kids, we're dealing with families. So this really is a family and community issue. Thank you.
Thank you very much, Ms. DeGoo. Both of our witnesses bang on time, so thank you very much for that. We'll now start our round of questioning. Each party, of course, will have 6 minutes in the first round, and we'll begin with the Conservative Party. Ms. Goodridge, the floor is yours for 6 minutes.
Thank you, Dr. Ellis. Thank you to both of our witnesses. I want to start out by thanking you guys for the work that you do to provide assistance to kids and families in our country. That's spectacular. Ms. DeGoo, one of the things you said, especially right at the end, was talking about how this really impacts the entire family. It goes beyond the child. And I could really relate to some of what you were talking about, being someone that I represent the riding of Fort McMurray Cold Lake. So a rural riding that has a few more challenges, probably very similar to your own, where people have to drive long hours to get specialized care in many cases. And perhaps we don't always have internet capacity to even have some of the digital options even available. What could you add to that? Do you have any solutions? And perhaps you could expand a little bit on that.
Thank you for the question. And interesting when you talk about Fort McMurray, because I think we have several families that kind of go back and forth also between our communities. So there's a whole other family issue of one parent we're often working away. Locally, in our Nova Scotia government has been working hard to try to make sure that there is access to internet services. It's just not happening fast enough. I think COVID, we saw the impact of that in terms of disparity in what people were allowed to, were able to access for school. I think, and even with the self-service, I think there's attempts, but I'm not sure how much that's been happening for the pockets of the areas around us that don't have it. I think it needs to become an initiative from the government that it just, from a safety point of view, even families need access to Wi-Fi and to self-service these days.
And I guess one question, you touched on the fact that there are long wait lists, even private providers are having exceptionally long wait lists. How does this impact children when they do not get the care in a timely manner?
I think they end up seeing someone like Dr. Black, right? If we can catch the issues early enough, both within the family and for the child specifically, because they don't live in a silo. So the parents and family also need support. But when we don't, have access to services for our children, they do end up in crisis, and they end up with self-harming. They end up with maybe more intensive eating disorders, something that may have started as a bit of emotional eating can turn into a full eating disorder. And they end up being suicidal, and they end up in our ERs. And then the ERs don't know where to put them because there's so many wait lists to try and get them in to see people. So I think Dr. Black's work is really important for that.
No, that's fantastic. I guess I will open this up to either of you. I am the Shadow Minister for Addictions, and I know that we've been anecdotally seeing more and more kids presenting with addiction issues at younger and younger ages, and I'm just wondering if you guys can touch upon that and if you have any possible solutions.
Thank you for the question. I'll start. Contrary to that sort of feeling, we're not seeing increases in youth addictions. In fact, kids are using less and less substances over time. It's been going down. If you do a survey of kids, it goes down by about 2 to 3% per year. Number of kids who use certain substances. Of course, during the pandemic, we had this counter thing because of the toxicity of the drug supply, where some drug overdoses increased. Mostly youth were spared from that, but obviously 20 plus, it hit quite hard. But the substance use issue is always one of access. Whenever I have a child who has substance use issue, there are very few places that do co-occurring work. So if you have suicidality and you have an addictions, many places will say, we can't help you because you're suicidal. And if you have addictions and then you become suicidal, you're removed from the program. And so we need a lot more cross, what we can call concurrent disorders care, because of course addictions, mental health issues, and physical issues all work together.
No, and I think that you highlight an important piece. I know we have a spectacular facility in Alberta, HESA House, that treats children that have concurrent issues, and I was lucky enough as the MLA for my riding to get a couple little kiddos that really needed some help to get down to HESA House to get the help they really needed. But it became evident that we just don't have enough of these facilities. We don't have enough of these people. Do you think that there is an issue in terms of the amount of people that are working in this field to actually be able to address the issue at hand?
We have lots of dedicated and hardworking people. I think it would be fair to say that we need more. The issue is, I work in a tertiary hospital where, there's a certain number of hospital beds, but really there's a group of children who aren't sick enough to require full hospitalization and are really struggling such that it's hard to get their day-to-day work done. And so programs like day treatment models, outpatient facilities, home-based care, for these kids that are in the middle, these families that are dealing with escalating crises, that's where there's a huge lack of services and beds. Of course, we also need more.
Thank you, Dr.
beds.
Black. We'll stop there. Appreciate that. Now we'll turn to Dr. Plosky. Dr. Plosky, you have the floor for 6 minutes.
Well, following up on Layla's question, I'm going to ask a somewhat similar question. Now, Dr. Black, you did talk about what to do with children who both had mental health issues and were suicidal, and I guess somewhere in there was also addictions, because you were responding to the problem of addictions. Now, as I think you know, a lot of overdoses in youth are by people who don't necessarily have mental health problems. But we're studying children's health, and I've got a lot of kids, but I've got a 12-year-old and a 14-year-old, and I think for most of us who have teenage children, are either our biggest fear or one of our biggest fears in terms of their health is that they're going to overdose. And not that my kids seem likely to do it, but when you're a teenager these days, and when they're drinking in a place like Thunder Bay, which I hear, I don't know if it's true, has a higher per capita rate of overdose deaths than Vancouver even, there's certainly a concern that at some party they're going to do something, and all it takes is one time, and the stuff they're doing is laced with fentanyl, and that's it. So what can be both of you tell us as to what either parents, teachers, schools or governments can do in order to address this problem and to try to prevent overdoses amongst youth?
I'll go ahead. I think it goes back to early access, and I think often when it comes to drug use with teens, they're getting education within the school, but I don't think they often hear it. I think they need more real life experience type of learning and hearing from people who've experienced. When children are starting to kind of dabble in whether it's marijuana or whatever, and sometimes they're dabbling in marijuana and somebody ends up puts something in what they're taking, and that ends up in an overdose. We need to be able to have open conversations with them about using marijuana and in a non-judgmental way so that they can have open conversations. We have a woman out of Dartmouth here in Nova Scotia who several years ago lost her daughter's first time ever taking a pill at a party, and she died. She didn't wake up the next morning, and she's doing a lot of advocacy work. Her name's Dale Gelada, and she's done lots of advocacy work with schools, with government, so I'm more than willing to pass on her information if that would be helpful for folks.
I think when we're working with children, especially at the teenage years, we often have to recognize how important it is at that stage of their life to figure out who they are, what they're doing, have autonomy, have responsibility. And that means as a parent, when you have those worries, making sure that your children have the information and the access so that if they ever are in trouble, the people that they can call are the people that love them the most. So I'd really encourage families and systems to work in models that are non-judgmental, that use the evidence base of harm reduction, and work with children at the stage they are. A 14-year-old really can't be told what to do. They can be guided what to do. And if you're non-judgmental with your children, you approach them with a caring compassion that says, wherever you are, whoever you are, I'm here for you if you need me. Then if they ever get in a situation where they're in trouble, you've opened a door that they can come to you.
I think that's good advice. I guess mostly to Dr. Black. I know you work in Vancouver, and I'm sure that there's probably a fairly large Indigenous population and people who maybe are from more outlying communities coming to Vancouver. I wonder if you could comment on, and perhaps both of you may have some comment on this, on the success or lack of success of the Western psychiatric system in dealing with either mental health issues or substance abuse within the Indigenous community. I know I'm on another committee, which is INAN, and certainly in that committee, we had a bunch of witnesses from the Indigenous community asking for more funding for non-insured health benefits, in that it would allow people who are more Indigenous healers, for example, to be part of the process, perhaps also along with people in the Western psychiatric system. So any comments on that?
Absolutely. I think psychiatry, medicine, and generally colonizing society has to grip with the facts that there's been significant trauma and mistreatment delivered to um, Indigenous families on the basis of care. And Indigenous families need a voice at the table. It's really important in any facility, treatment facility, to have Indigenous representation in the design, in the feedback, and when working with Indigenous families, making sure they have access to important cultural care. So systems need to be set up for Indigenous care, and the situations I get in the emergency department are often big time crises. And when that happens, we invoke things like the Mental Health Act, we invoke things like Section 28, where the RCMP bring children in. And
Dr.
so,
Black, I'll stop you there.
Yeah.
Thank you very much,
Okay.
sir. Appreciate that. À la prochaine.
Next, we'll have Mr. Champoux. Welcome to the Health Committee. You have the floor for 6 minutes. Thank you very much, Mr. Chairman. And it's my turn now to thank the witnesses who are with us today. Dr. Black, I thought I understood earlier that you said that we hadn't necessarily seen an increase in drug use among youth. Did I understand that correctly? Is that what you stated?
if we're referring to like the percentage of children who use substances, that number has been sort of steadily coming down for years.
Si on parle
If we are talking, for example, about adolescents, earlier my colleague Dr. Poplawski spoke about that. I have some at home as well. And we know that adolescents have a tendency to do all kinds of experiments. We've all been through that. So have you been able to see, both of you in your respective practices, any change or modification or perhaps increase among your adolescent clientele since marijuana was legalized in Canada, and since, I would say, we have made it appear less diabolical, if you will? So have you seen that more young people turn to those kinds of products rather than alcohol, which was more easily or readily available to them, now that marijuana is accessible to them?
Marijuana remains inaccessible to children, even under legalization. But of course, children, since the dawn of marijuana, have had access to marijuana through other routes. The statistics we're starting to get, and of course, legalization is a recent phenomenon, suggests that we have a continuation of less and less kids
Monsieur le
using
Président,
marijuana.
Mr. Chairman, I'm told that the interpretation into French is not working at the moment.
Voilà.
Okay, it's working now. Yes.
Please continue.
Thank you.
So numbers have been coming down. What I see typically is every generation, every new wave of kids that I've worked with seem more responsible, more connected, more socially engaged, more caring about outcomes. I know there's a feeling sometimes that things are getting worse and worse, but that's never been borne out in the data. This generation of kids use the least amount of drugs, have the least amount of sex under 13, have the least amount of violence. Some of the moral tropes that go on about kids are not reflected in the data that we see with kids.
Okay. Je reviens à la
I'll come back to the question, or the more specific issue, of mental health among youth. You spoke about the fact that you would like to have more standards, more programs for mental health across the country. You know, and this is one of the things that my colleagues and I have said repeatedly, that health issues are obviously come under Quebec and provincial jurisdiction. So in BC, and I won't ask you to comment on all of the provinces, but do you have confidence in your government in BC to manage the health care system right now? So how's it going there?
I mean, every jurisdiction that I've known including BC, struggles with wait lists and access to care. I don't think I'm aware of a Canadian jurisdiction that is completely nailing it. I do think as overall as a country, we spend less per capita on mental health than most of the developed nations. And mental health, especially for children, is a foundational element that will impact the rest of their lives. It would be a really good return on investment for governments to put more money into the well-being of our children. So generally, I'd say, it'd be hard to look at the wait times that families report and the lack of access to care that families struggle with and give any jurisdiction, including BC, a high mark on a report card.
Madame Digou,
Ms. Digou, in Nova Scotia, how are things going? Do you have confidence in the provincial government to manage the healthcare system?
I think I agree with Dr. Black in that what we're seeing with the wait times is things aren't being well managed. I think our government's trying hard to look at alternatives. One issue that I'm seeing in colleagues, both within the formal mental health system and hospital system, as well as people in the private practice, is burnout. We need more bodies, and we need more bodies doing the type of work that they're good at. So instead of throwing people in and expecting them to just jump in, we need people doing what they're trained to do. And I think that's one of the issues within the system.
Je pourrais pas être plus d'accord avec vous.
I couldn't agree with you more, but don't you both agree in just a few seconds on the fact that if the federal government starts to give money with strings attached to the provinces and to Quebec for healthcare systems, that it might not complicate things even more? Wouldn't it be simpler to do, as all the premiers agree right now? We've heard it on radio shows across the country right now. They're begging the federal government to stop attaching conditions to healthcare transfers and to increase it to 35% by 35%. So wouldn't it be better for Quebec and the provinces to put that money directly into the specific care and mental health for children, for example?
I'll have to ask both the witnesses 2 or 3 seconds each, or we'll come back to it.
I'll leave those decisions to those with the expertise. I'd say more money is good.
I concur.
Merci à tous les deux.
Thank you both.
Very well done. Impressive, in fact, I might say. That being said, I'll try to avoid the commentary here. Mr. Davies, you now have the floor for 6 minutes, please.
Thank you, Mr. Chair. Dr. Black, if I may start with you. In an August article in Scientific American, you stated that pediatric suicides and mental health crisis rates increase sharply when school is in and ease when school is out. You noted that that pattern is also found in other jurisdictions such as Japan, Germany, and Finland. Can you explain to us why that is?
Well, the whys is always challenging. We've noticed this. Anyone who works with children knows that they're more busy during the school year, and when school gets out, there's just less business. And I think it has a lot to do with the fact that school is like a job for kids. School has, your coworkers, your boss, your supervisor, your overtime, which is homework, your hours, what you don't get often and kids fail to recognize is the benefits like wages. So like children, school is a big deal. A study in 2014 showed that 84% of children reported that school causes them anxiety. And so, there's so many things that schools could do better, like the hours of service, lessening the amount of homework, access to mental health curriculum, creating safe spaces for kids who are neuroatypical or those types of things. There's so many things that schools could do. I think you could just ask a random sampling of 10 kids, what do you think schools could do better? And you get a host of responses. School is just a really stressful thing for kids, and we see a 60% increase of suicides during school days. And in ERs, we see 100 to 150% more kids on school days than non-school days.
Thank you. Now, in a 2018 Ask Me Anything Q&A answer interview, you said the following with respect to mental health wait times in Canada, and you've touched on that in your testimony today. You said that your 6-month wait is unacceptable to see a psychiatrist if you're struggling with a possible illness. Is there any research that you're aware of on a connection between lack of access to care and increased suicide?
I mean, to develop evidence like that would be challenging. Like if we wanted causative evidence, we usually do things like randomized controlled trials, and it would be pretty unethical to put people on wait lists and see. I think what we typically see, though, is many of the patients that I see in the emergency department had issues that maybe I'm just coming off as like an expert who looks backwards or something like that, but I always think, 8 months ago, I could have really helped a lot easier with this than the situation that I'm in right now. What we know for sure is unaddressed, untreated mental health issues, untherapized mental health issues, and for kids, I have to say, therapy is super important and even harder to access than medications from a family doctor or psychiatrist. These things, if they're not addressed early, they fester, they grow. And many of us know adults who struggle with major mental health issues because of childhood issues that were never addressed. And so it's just one of those things that is really important.
Yeah, I'm reminded of that phrase that we don't need research to tell us that water is wet.
It's challenging to do.
I guess you would agree with the proposition that the longer that we wait and deny children access to necessary therapy, I think as a general proposition, it would increase the risk of suicide. Would that be a fair thesis to suggest?
Absolutely.
Okay. Madame Degout, you touched on this. I'm wondering if you could outline how social determinants impact childhood mental health in Canada, and maybe if I single out poverty as an example. Is there a link between poverty and mental health problems in children?
I don't know exact research studies, but I'm sure they're out there. I think even, just common sense. I have families who have to make a decision between whether they can afford to take the afternoon off work to be able to take their kid to therapy, or whether or not they can afford their child's medication, choosing between rent and medication if they don't have service. But I think just even accessing, so one anecdote is I worked with a young adult years and years ago, and I remember one day his parents were in survival mode. They literally were going day to day trying to get food on the table and trying to provide the basic necessities. And this kid was very engaged in therapy. And I remember one day, he walked 20 minutes in the pouring rain on his own to get to his therapy appointment. Kids want it. They don't always have the opportunity to get it. And the barriers are just huge when it comes to the poverty aspect. And nutritional food, ability to, get out and do active living sometimes is very difficult for families. And I saw the 1-minute sign, so I'll quiet.
You actually anticipated where I was going next. Dr. Black, I just want to ask you, are you aware of any research of a connection between poverty and childhood mental health issues?
Absolutely. So we know that socioeconomic determinants of health are correlated. I'm happy to forward some links to the clerk to share with your committee. There's recently been a study even linking suicide rates in children and adolescents to poverty. It is a variable that we consider, and again, will we ever establish cause with evidence? Probably not, but it'll be compelling evidence when it's seen.
Thank you.
Thank you, Mr. Davies. Thank you, Mr. Black. Dr. Black, I apologize for that. So that ends the first round of questioning. I'll just bring it to the attention of the witnesses that there are differences in time, and I'll make you aware of that as the member begins their round. So for round two, I'd like to welcome Mr. Vidal to our Committee on Health. And Mr. Vidal, you have the floor for 5 minutes.
Thank you, Chair, and thank you for having me here today. And like Dr. Plowski, I typically sit at the INAN committee, so I'm kind of bringing that flavor to this I quickly looked at the motion last night, and you know, the sense of it was disparity in access to health service for rural, Indigenous, and lower income folks. And as an MP that serves the northern half of the province of Saskatchewan, 71,000 people over about 350,000 square kilometers, or just about the size of Germany. I think I bring some of that flavor to the table, so I appreciate the opportunity today. And I appreciate your witnesses in the testimony you had, and just a couple quick questions that I would like to get to in my time. Obviously, remoteness and distance from services is a big deal to a community like mine, and access to professional services, or to communities like mine. One of the things I heard last week from some leaders in my riding is that during the pandemic they had access to remote mental health services. They were doing it via virtual meetings and that kind of opportunity, and they're very concerned that is going to end. So my question for you is a little bit twofold. Is that concern valid in the sense of losing that? I mean, obviously that's significant, but can you speak to the opportunity or the quality or the ability to actually provide those services virtually? Because that's a big deal when you're 6 or 8 hours away from the nearest professional. And I would quickly go to both of you if you don't mind.
I'll try to be very quick to give time for our other witness. The virtual care is crucial. We had it generally before the pandemic. Obviously, the pandemic forced us all to be doing it. And in 2022, despite most of our patients having the physical and COVID abilities to come in, many patients still choose virtual because of the ease for them. Psychiatry, there's occasions that I need to do physical exams, take measurements, see people in person, and I always will need an office to be able to do that. But the delivery of care virtually safely is really important. It would require making sure that we have the infrastructure, that patients and families understand the importance of privacy during those times, that we have good audits to make sure that the quality of care doesn't decrease. But I can say without question that most of my patients and families prefer virtual appointments in 2022 over in-person appointments, and I think we have to consider why that is.
And I would agree that, many of my clients are still continuing to request virtual. Some kids are just more comfortable with the screen as well, which I think is important when we're doing assessment and working with kids. I don't know in terms of the formal systems whether or not they will be continuing. I hope they will, because I do think, it's become vital for accessibility.
I appreciate that, because that confirms for me the sense of advocating for those to remain. So that was kind of the purpose of my question. Mr. Go, a quick question for you. You talked about food security in your comments, and again, I'm going to reference this particularly to my riding, where I have communities that pay like $14 for a gallon of milk and $9 for a dozen eggs and $12 for a kilogram of apples. It's obviously a huge issue in some of the very remote communities because of freight and those kind of costs. So can you just make the link for me, or flesh out a little bit the food security connection to mental health and how that might affect people in those more remote regions that face those very, very high food costs?
Yeah, I think it's food security is an issue in all communities. I think it's probably worse in remote communities like yours, where it's much more expensive. But I mean, I always go back to the idea food is like a calorie is an energy unit. If we're not providing kids energy and the nutrients they need to be growing, their brains need it, their bodies need it. So, to me, it's integral to good mental and physical health to be able to have food. Families are not always able to. There's some great community opportunities and to provide community fridges and things, which can help as well.
Thank you. And Dr. Black, a really quick question, because this chair is going to cut me off. You talk about this ASARI tool that you've developed. I'm really just curious if that is able to be used. I don't know much about it. Can it be used in rural and remote settings virtually, or how can that be used by other people?
The ASARI is different than a lot of assessment tools. It's not really intended to score risk What it is intended to do is allow the clinician to completely document what they're thinking and communicate what they're thinking about suicide risk. It's accredited, it's used in places all over Canada, and it can be used in any location. And it's available for free at the website that I've set up, asari.ca, asari.ca.
Thank you, Dr. Black. Appreciate that. Thank you, Mr. Vidal. And we'll turn now to Mr. Vancouverton. You have the floor, sir, for 5 minutes.
Thank you, Mr. Chair. It's nice to follow Mr. Vidal as I used to when we were on INAN together, and I hope your work continues to be rewarding and productive on INAN, as I'm sure it is. Thank you to our witnesses today, not just for being here and providing really good testimony, but for your extraordinary work. I don't need to tell you, but I do want to emphasize how important your extraordinary efforts are in society, and you save lives every day, so thank you. My first question's for Dr. Black, and it surrounds the first thing that you started mentioning with respect to the attacks that you've experienced with respect to mis and disinformation. I think mis and disinformation should be differentiated. There's intentional misinformation. There's information that goes out because people are ill-informed, and there's a very important divide here between intent. A lot of people who are spreading misinformation are doing it in the efforts to help. A lot of others are doing it with the intent to harm, and I think those need to be differentiated. But if I was just hoping that you could elaborate a little bit on your experiences and what our government could do to counter misinformation, disinformation, malinformation, and what do you think our obligations are in that regard?
Thank you so much. This is a question that I've thought a lot about. I've been in the online space doing advocacy, and in online, the amount of disinformation and misinformation is tremendous. And I think we have to start really considering the weaponization of disinformation as a threat to Canadian lives. There are many people who died of COVID because of disinformation about COVID and the vaccines. There are many people who have not done what they could to protect themselves out of disinformation that was spread. And disinformation on vaccines goes back well before COVID. These are intentional actors who choose to spread disinformation for either personal gain, political disruption, anti-authoritarianism, these types of things, and it's a threat to people who are marginalized. It's a threat to people who don't have the ability to know what all the latest science shows. And disinformation online can be very compelling. I think the government has a strong obligation to fight disinformation. I'm part of a group called Science Up First, which is led by Tim Caulfield out of the University of Alberta and Senator Stan Kuchar. And we work really hard to distribute information that sort of counters disinformation. But I think the government has to seriously take, knowing that we have freedom of expression, not freedom of speech, has to seriously take the threats that that disinformation has. Misinformation goes, people will think things. I'm used to myths. It's okay to battle myths. But disinformation is intentional, it's subversive, and it's extremely alluring to people for very important psychological reasons.
Could I just ask one specific question about that? When I think about mis and disinformation, I also consider the relationship of an act of omission and an act of commission. And an act of commission is saying something vis-a-vis vaccines are very good and you should get vaccines. You should get vaccinated. And I just made an appointment for my flu shot today. Whereas an act of omission might be a reluctance to say such a thing given an extraordinary platform. Can you speak to that at all?
It's challenging. What we do and what we don't do obviously impacts the outcomes that we care about. And many physicians, unfortunately, have chosen to be silent in the face of disinformation. I think disinformation requires us to be active in fighting it, not just putting out pamphlets or saying, I'm a doctor, come talk to me, but actually fighting disinformation. And I think there needs to be serious ramifications for doctors who go against or use disinformation. And we're starting to see doctors having judgments in the United States. And I think there's been some interesting developments in Canada. So it's very important.
Thank you. I have one quick last question, and it's around physical activity. I'm an advocate for kids getting enough physical activity, and I see the rates of that declining. And both to doctors Tico and Black, I I recognize and appreciate your pragmatic optimism with respect to the state of affairs, Canadian kids. But can we speak, perhaps Dr. Digo, I don't have long, but have mental health practitioners investigated things that you could perhaps prescribe in the meantime when there is that unfortunate lag time around physical activity, being able to get outside, and just speak for as long as you can about the positive impacts of physical activity on youth and mental health?
Yeah, again, there's tons of research on this, and we do know the importance of, getting out and being active. I think for, some of our neurodiverse clients, it's even more important to be able to get out and get active and get moving. I'm not sure if I'm getting feedback there.
I'll stop you there, Ms. Dugu. Thank you for that. And thank you, Mr. Van Couverden. The next round of question goes to Mr. Champoux, and I'll underline for our witnesses, it's 2.5 minutes. Mr. Champoux, vous avez la.
You had the floor. Thank you, Mr. Chairman. 2.5 minutes is quite quick, so I'll try to ask a question that won't require too lengthy a response. My question is open to both witnesses. Are you inspired by the practices of other countries? Do you see other countries where they're doing better than we are here in Quebec and Canada in terms of mental health and prevention, particularly for children and youth? Could you give us any examples of countries that are doing better, and what are they doing that is different?
Madame Digo.
Ms. Digo.
Ou Dr. Black, je veux dire, un des...
Or Dr. Black, one or the other.
I'll quickly go and give Ms. Good a chance. For me, I care about standards, and many nations have taken the issue of health standards more seriously. In fact, often we borrow from UK, Australian guidelines because Canada doesn't have its own specific, that we provide healthcare, and yet we leave it very much open to healthcare providers on how to do so. And it's very important that we have standardization. So when I think about NICE in the UK, for example, as an example, something that really helps guide people for treatment, it's very scalable. And so that would be one example.
Madame Digo, de votre côté, est-ce que vous...
Ms. Digo, do you have any examples to share with us?
I don't really. I certainly often go to the UK psychological, the website, I can't remember the name of it, but I do continually look at their standards, and there's a few programs in the UK that I do often turn to when I'm looking for ideas for things, but I really don't know much about other countries and what they're doing right now.
Thank you. I'll continue with you. I have a few. Do schools play an adequate role, in your opinion? Do teachers have the right tools to inform youth?
I think many teachers do. I think certainly Senator Kuchar has done a lot of work working with schools in Nova Scotia. He's set up some great programming for teachers to learn about mental health and the language around mental health. So it's coming. I think it's a matter of some teachers are very comfortable talking about mental health and some are not.
Merci beaucoup.
Thank you very much.
Thank you, Monsieur Champoux. And now, Mr. Davies for 2.5 minutes.
Thank you. I've seen statistics that say that about 32% of Canadians have no access to dental insurance, but it's about 50% of low-income Canadians don't have access to dental care. This is one of the few areas of healthcare where the effects of poor health are visible and they're on our face. I think it's well documented that dental issues cause pain, but they also cause embarrassment and shame. So I'm just wondering, with respect to children, is there any connection between poor oral health and facial disfigurements and mental health? And would you recommend that we address that gap in our healthcare system as a means of dealing with children's mental health issues?
Yeah, yes, absolutely. Children are very sensitive to ways in which, if I would say newest generation is much better at not teasing or picking out differences in kids, but kids are still kids, especially in middle school. It makes it very hard. When I think about this, I think there's a neglected population in neurodiversity. I work with a lot of children who have autism, who have neurodevelopmental disabilities, intellectual disabilities, and many times they're hospitalized with severe aggression, hurting themselves very severely because of poor oral care. Pain when you can't express where it's coming from can result in head banging, lots of injuries. And so we certainly see oral care relating to hospitalizations. I've had many hospitalizations where the solution is consult a dentist. And I'm in a mental health facility, so certainly oral health matters. And when we think about what makes kids feel like, confident and, if they're having pain or if they're having some form of deformity that makes it, obvious, this is going to impact their mental health for sure.
Ms. Degout, do you have anything to add?
I think the only other thing I would add is with the neurodiverse community, there's often some difficulties around even performing daily oral care because of sensory issues. And I think it's a really important role for mental health clinicians and occupational therapists often, particularly, to really work with kids who have sensory issues. So it's really even painful for them to brush their teeth and they can't get past it. So there's the way things look, but there's also a big issue around ensuring proper care. And there are other mental health issues where dental care becomes an issue when hygiene, kids can't take care of hygiene. And I'm thinking early psychosis, that's one of the things we often see regularly is we start to see some of those pieces not being done daily.
Thank you very much, Ms. Degout. Thank you, Mr. Davies. At this time, we'll return to Ms. Goodridge. Ms. Goodridge, you have the floor for 5 minutes.
Thank you, Dr. Ellis. I want to go back to something that I had asked about earlier about the children's substance use. When we had earlier in the study, we had Bruce Squires from McMaster Children's Hospital in Hamilton, Ontario, come before the committee. One of the things he shared with our committee is that they had seen a 90% increase in admissions for eating disorders and a doubling in admission for substance use disorders amongst the kids that were coming into their space there at McMaster. And to me, those numbers are extremely troubling. And then Dr. Black, you shared that this is actually going down from what you've seen the statistics. I'm wondering if you can table with the committee the statistics you're referencing, because it's either doubling or it's going down, but I think this is highly problematic that we don't have perhaps all of the right information. So would you be willing to table that with the committee?
Yes, and if I may, Ray et al. Published in Journal of the American Medical Association a study of Ontario admissions for overdose and self-harm, and we have the McCreary Center reports on that I'd like to enter, so that you can have access to some larger Ontario data.
Thank you. I will note, and I'm not sure, I'm hoping that all members have done the required sound checks before participating, but it doesn't appear like you're using the House of Commons headset, and there is some challenge in hearing you. Do you by chance have that headset so that we can make sure that we're protecting the health and safety of our translators?
Certainly. I can use it. I did the sound check and they said that it's good.
Fantastic. It's just one of the interesting challenges we've been having here with the House of Commons, especially as we've gone to a lot of hybrid, is injuries of our translators due to people not wearing appropriate headsets. And so it's just something that I think is good practice. And I apologize for not catching that earlier, but better late than never. And it might prevent an injury from one of our translators. And I want to... You talked about the need for more harm reduction. Do you believe that there are enough treatment spaces available for children that have substance use disorders in this country? And do you believe that treatment and recovery should be put before harm reduction?
Sorry, I'll switch my audio as soon as I can. I just didn't want to delay. The harm reduction is an element that comes first, and it's certainly we need treatment when it's needed. You need a child who typically is willing to do treatment, who's in a state of change where treatment will be fruitful. But of course, when things are in crisis, we need acute access to treatment and withdrawal management and those types of things as well. But harm reduction is an overall philosophy that starts even at the family table, kitchen table, and works all the way through to the hospital environment. And so certainly harm reduction is a model that can apply at any stage, even early.
Yeah, thank you, Dr. Black. And I would argue that would be more in the education and prevention aspect of those conversations. And they're critically important. And I don't think as a society we do enough to alarm our kids about the risks of addiction and substance use disorders as a whole. And I would hope that each and every one of us can be champions for reducing substance use disorders. I know that it's disproportionate in many of our rural and isolated communities that often will end up having suicide crises happening because they do not have adequate support. And I see that I have a minute left. Perhaps, Ms. Dugu, you could highlight what you're seeing in rural Nova Scotia when it comes to some of this issue with addictions.
I agree with Dr. Black that the harm reduction philosophy, I think, is kind of, I guess that's the standard in which we have to start, where we have to start. But we don't have enough treatment facilities when they are required. And just around harm reduction, there's actually a very specific way to use harm reduction in therapy. So it is a proactive, and it's a family, it's an educational issue. But within therapy, it's very specific, looking at ways that a child or a youth can start examining their own use and does it create harm, and are there ways that they might want to reduce? Are they interested in kind of reducing harm? And being able to see it. So there's a therapeutic modality of harm reduction as well as the philosophy that kind of is the overarching ideal.
Thank you, Ms. Dugu, and thank you, Ms. Goodridge. I'll now turn to Dr. Hanley. You have the floor for 5 minutes, sir.
Thank you very much, Dr. Chair. I would like to I'd like to thank both of the witnesses for your testimony today, and like Mr. Van Couverden said, for your amazing work. The general theme, I think, in my questions is addressing our previous study, which we're just analyzing the report on, and that's on the healthcare workforce crisis, with a lens around mental health needs and how we get better, not only on the prevention side, but at maximizing access to service. So it's in that vein, Dr. Black, first, briefly, to follow up from Mr. Vidal on the use of the SRE tool, are we doing well enough in both risk assessment in the emergency department amongst our healthcare providers, and between the heart map and the SRE tool, are these tools that are already helping us be perhaps more consistent in how we do risk assessment and communicate that risk assessment? Maybe you could elaborate on that a little bit. We're not hearing you now.
Dr. Black, we don't have any audio, and by the visual it says you're on mute.
I've just switched back. Still trying to figure out the headset because I didn't test this one. My apologies. The ASARI and the HEARTS map, when used, can be really helpful in both documenting risk and communicating it, as well as the HEARTS map in its psychosocial assessment. And the HEARTS map actually calculates what an emergency physician could consider next as a course of action and who to consult with, not just mental health, but social, physical needs, youth health needs, these types of things, and it would be really helpful to be used. Risk assessment in general, it's very hard to predict who will die by suicide and who won't. In fact, there is no risk prediction system that gets better than a positive predictive value of 1%. And so risk assessment is often trying to figure out what are the risk factors that make their suicide more likely and what are the protective factors that would make it less likely, and trying to cut away as many risk factors as possible and add as many protective factors as possible. So this is something that every human working with kids can do. And so I see a lot of efforts zeroing in on prediction, and I wish the science were there, it's just not. But risk reduction and protection increase, these are very achievable goals in any setting, including emergency departments.
Thank you. That's very helpful. Mr. Gout, I'm hearing from private clinics in my territory, like yours, long waiting lists, often having to provide pro bono services to those who don't have coverage, short-staffed, often overwhelmed due to the demand on the public mental health and addiction service being itself backlogged. And you've spoken to this, and I'd like you to elaborate a bit. When I think you mentioned the possibility of or advocacy for MSI coverage for your cadre, and I know I've heard that, and so maybe you could speak to how you think that would help improve access to mental health services if your cadre of service was actually covered under the public health insurance plan.
I know there's currently debate in Nova Scotia around how to make that work, because our government is strongly looking at a way of billing private practitioners. And I think just the difference between clients who have private health insurance who I can direct bill compared to the people who have to pay upfront and then get reimbursed, or they're paying out of pocket. The difference in terms of the ability to, I think, not get stressed over the finances of it is really important. So from a practice point of view, taking that stress of the financial off of the client and the family is really important. And for us as practitioners, there's nothing more heartbreaking than having to turn someone away because you don't have space in your schedule, or you already have 5 people who are pro bono that you're seeing, and you just physically can't continue to do that or financially continue to do that. And it's heartbreaking, and we talk about burnout. Those are the types of things that burn out psychiatrists and psychologists and social workers, I think. It's not the work when we're helping, it's the when we can't provide what we know should be there.
Thank you very much, Ms. Good. Thank you, Dr. Hanley, for that. That concludes 2 rounds of questioning. The 3rd round of questioning will be to Mr. Vidal for the Conservative Party for 5 minutes.
Thank you, Mr. Chair. I want to follow up on a couple things that have been said earlier. One by Dr. Hanley that talked about kind of the staffing issues that we're seeing in facilities and whatnot here. As a bit of an example, there's a facility that was announced and built in my riding. It's a facility for the treatment and recovery of those dealing with mental health problems and addictions. It's a 20,000 square foot facility, $16.1 million invested in this 24-bed facility. Was announced and opened in June, and I had the privilege of touring it in July. And much to my chagrin, it was empty. There wasn't a patient in the facility because they don't have the staff. So I'm just curious to hear your response and what level of frustration that would indicate for you in your worlds when we build a $16 million facility, but we don't have the wherewithal to actually staff it.
It's very frustrating. This happens in hospitals where bed decisions and treatment decisions are changed based upon staffing levels. This is something that we we encounter regularly. You can make a space, but it needs, Ms. DeGo was mentioning, it needs bodies. We need people doing what they do. And we've had a tremendous amount of burnout. We have a number of people leaving. It's very hard to replace people with experience. And we're finding that many facilities are struggling with staffing issues on a daily basis. So it's not just about providing a space, but making sure that that space includes the humans inside it. And that requires an ongoing commitment. And I do think that, if you look at relative to other things that people could be doing with their time, sometimes it becomes very disheartening to work in mental health, which always seems a little bit neglected compared to other areas of health.
Mr. Go, do you want a quick comment, or do you want me to just move on to my next question? I can come back to you with it if you want.
You can just move on.
Thank you. All right. So one of the other comments you made in your opening 5 minutes, and I know you're very limited there, was you talked about culturally appropriate services, and in contrast to the facility, which would be culturally appropriate as well if it was actually open and serving people. I want to give it that credit, right? But there's another facility that is looking for some really, really small levels of funding, and they would provide very culturally appropriate, land-based, and the thing I would add to that, which you also mentioned, services that would include the whole family, because I think that's absolutely central to us solving the issue of mental health and wellness and addictions recovery, is that we include the whole family. But yet an organization like that already has a facility that needs some really small investments can't seem to get those investments. So, sorry, and I don't mean the question to be one about the negative around the investments, but just can you speak to how important that combination of culturally land-based, family-centered treatment would be in the context of mental health and addictions, please?
I think having the opportunity to provide clients different types of therapy, whether it is land-based, whether it is, specific to their own culture or more Western-based medicine, is really important, because sometimes people will surprise you. But when we make the mental health treatment about the one child, what happens is they become, everything seems to be around what they're doing wrong instead of setting up what's happening within the family. And I think sometimes we can do that family work better when we're outside of the therapy room, doing home visits, doing something constructive, and looking at the way the family interacts and communicates with one another.
Dr. Black, do you want to comment on that as well? I have 30 seconds left, so I'm not going to start another question. Try to be brief then. I think anytime we have an opportunity to listen to Indigenous voices and develop programs that work for Indigenous people, we should embrace it, we should fund it. This would be an anti-colonial approach of centering power in Indigenous hands, and I would be all in support of it.
Thank you, Dr. Black. Thank you, Mr. Vidal. Mr. Johari, you now have the floor for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for your testimony and your hard work and advocacy on mental health, specifically on children mental health. Dr. Black, I'll start with you. In your opening remarks, you talked about, as one of your recommendations, federal standards for early care. And also, Madam Duguid, you also talked about early access, and I'd like to open up the conversation in line of questioning around what are your recommendations around federal standards, and how can we collaborate with the provinces to ensure those standards are not only implemented but are measured and reported. So if you could demystify what those federal standards should be and give us some recommendation around collaboration, really appreciate that. Thank you.
Sure. It's probably well known that politically wait times are a thing, and so the publishing of surgical wait times, the publishing of ER wait times is something that has a tremendous amount of political power, and this generates ideas to improve the situation from all members of politics. In the same way, I think there could be standards that would really, when a child is in trouble, how long should it take for them to see a mental health professional, for example? The publishing, the encouragement of shorter wait times, this is something that could be, not only a national standard, but something that is well known. It relies on advocacy groups to talk about, in Ontario, I think about 5 years ago, or 3 years ago, I think it was, they published that some kids are waiting more than 2 years for treatment. So we need these standards. What they should be would be based off of tiers of care. When things are early, it doesn't require a tertiary emergency psychiatrist like myself. There are many professionals in many areas who have excellent training in all sorts of therapies. But when they need help, they should be able to access help. When that group needs help, they should be accessed all the way up to the tertiary services that are the rarest and most expensive. And so scaling these at a way that works with tiers of service would greatly reduce wait times. I do spend time assessing children that don't need to see me. And so establishing standards of how to access care in a timely way would be really helpful.
Thank you. Madam.
Yes, I agree the importance of a tiered system. And some examples when I was speaking of early access. So sometimes early access means, a child who's starting to get some anxiety going to school, being able to learn what that is, how that feels in their belly when they can't go to school, and then some coping strategies around it. That's a fairly quick intervention if we catch it early. If you wait too long, then that child becomes full school refusal. They may start engaging in withdrawing and, become depressed because of isolation and withdrawing. So if we can catch some of those things early, we have some amazing early intervention programs for children with developmental disabilities. Getting speech therapy early on is crucial when we look at outcomes from a behavioral point of view and academic success. So just those ensuring when we need it, we can get it, and with the appropriate person. A kid starting to get anxiety and a sore belly going to school definitely does not need to see Dr. Black. They need to learn some coping strategies.
So really what I'm hearing is access to the right care in a very step and structured point of view can shorten the wait time, which is a standard that we are trying to recommend or measure. So the standard is a multi-dimensional thing. I only got about 30 seconds and probably 15 seconds to each one of you. I want to get your feedback around a concept of integrated youth services, which in a direct way, both of you talked about, social determinant of health, social services, mental health support. What are your thoughts on that, and whether there should be direct funding from the federal government for it or not?
We have a model in BC that accessed some federal funding called the Foundry, and it's building integrated drop-in centers for youth that include health and wellness as well as mental health access. I think it could be a really good role for funding, yes.
Thank you, Dr. Black. Thank you, Mr. Johari. Michel Champeau.
Mr. Champeau, you have the floor. Thank you, Mr. Chairman. You have 2.5 minutes. In line with what Mr. Johari just said, that the federal government should send money to the provinces based on these standards. I understand, but 50 years ago, the federal government was funding health care to the provinces to the tune of 50%, and now it's 22%. So all of the premiers of the provinces and territories have unanimously been asking for a long time the federal government to up it to 28% and then 35% to restore some kind of balance. You know as well as I do, Dr. Black and Ms. Degout, as the provincial problems with healthcare is underfunding, and I think that all of the standards that the federal government may require in the for an increase of transfer are standards that already exist. They're already the ideals of the provinces and territories. So the answer isn't too very complicated. It's not to add standards. And the intention that the federal government might have for the province's provision of health care. It's just to send more money, and that's what we've been asking for years, to help us with our healthcare system. So I simply wanted to make that comment because it's clear we all would like to see a decrease in wait times at ERs, and we'd like to see people taken in hand, patients taken in more quickly, particularly ones who have mental health problems. They're often misdiagnosed, and often they're misjudged as well. So these are wishes that we all have. We all want to have a better safety net. And I think that that isn't something that's going to come through discussions on standards that the federal government might impose on the provinces and Quebec to send money here and there. So I just wanted to make comments on that. I admire your work. I think that you are essential workers and you're working under conditions that are deplorable. You should be much better supported, and that's what I hope comes out of these meetings, that money be sent to the right places and managed by the right people according to the priorities and emergencies of each of the regions in Canada and according to the needs, the specific needs that are not the same in one part of the country versus another. I thank you very much. It might be the last turn I have today, but I want to thank you very much for your presence here and for your extremely important and essential work that you do. And I hope that we'll be better able to support you. Thank you. Thank you very much, Mr. Champoux.
Turn to Mr. Davies for 2 minutes and a half.
Thank you, Dr. Black. Again, in a 2018 Ask Me Anything Q&A interview, you touched on the concept of misconceptions about suicide risk, and you've touched on that here today. Can you tell us what you think some of the key misconceptions about suicide risk are, and maybe on the flip side, what the key risk factors are?
Sure. Some of the big misconceptions that I deal with regularly are the close tying and connection of suicides to mental health. There's a myth out there that all people who die by suicide, or 90%, in many advocacy organizations still have this number, have mental health issues. Of course, the way that we know this is by a method called psychological autopsies, and there's some challenges with that. Whenever we do coroner reviews, and I've been a part of those, if we look at the National Institute of Health in the United States, we see that suicide is a factor, mental health is a factor in about 56% of suicides. And so this close linking between suicides and mental health doesn't address all of the suicide concerns we have. Some people have suicides because of issues that aren't related to their mental health, but their physical health, disabilities, socioeconomic determinants of health, those types of things. Another sort of myth about suicide that I'd like to sort of always battle is this idea that when we talk or we ask questions or we screen for suicide, we're somehow introducing risk into people. In fact, talking openly about it and having, I see the sign, having the ability to, interact with people on a human level about suicide actually protects. We have good research showing that people benefit from that. I think if we think about major risk factors, there's a laundry list, but I would like to posit that, we have our mental health, we have our physical health, we have systemic racism and exclusion, and in youth, we have discrimination on the basis of gender and sexual minorities, which is a large factor.
Just touching on that, my next question, probably have little time for much else, is for decades, mental health has been regarded as less critical to our overall health than physical health. Is it time, do you think, that we should add mental health treatment as an insured benefit under the Canada Health Act?
In 2 seconds or less, please.
It's more than time.
Ms. DeGoo?
Once again, I concur.
Thanks.
You guys are great. This is the easiest job ever. Thank you very much, witnesses. Thank you, Mr. Davies, as well. And now we turn the floor to Ms. Goodridge. Back to you for 5 minutes.
Thank you, Mr. Chair, and I want to again thank the witnesses. Having 2 witnesses for a 2-hour meeting is a lot to ask, and I mean no disrespect in this, but one of the issues that has been very top of mind for me, I'm a young mom, and through the course of this study and through the course of the last few months, I have on numerous occasions brought up the real serious concerns that have been brought to me by a lot of parents, moms and dads, regular people, grandparents all across the country that are struggling to find children's pain medication. And we're at a crisis level. We're at a space where it's on the shelves in the US in abundance. You can even pick your flavor. But in Canada, you can't find it anywhere. And this is especially troubling in rural, remote, and isolated communities, such as the ones that I live in, because we're a long ways away from a children's hospital if something does go bad. And so with that, I'd like to move a motion that the committee hold a meeting on Tuesday, November 15th, to discuss the ongoing shortages of children's pain medication, to include an hour of officials from Health Canada, and the second hour to include 1 witness from each political party represented on the committee. And to repeat in French, que le comité
That the committee hold a meeting on Tuesday, November 15th, to discuss the ongoing shortages of children's pain medications, to include an hour of officials from Health Canada, and the second hour to include 1 witness from each political party represented on the committee.
Thank you very much, Ms. Goodridge, for that. I'll just confer with the clerk to ensure it's all in order. Well, thank you for that, Mr. Clerk. Certainly, even though we would normally require a significant 48 hours for a motion, this is definitely related to the topic at hand, and certainly it's something I think that affects everybody here. So I find the motion to be in order, and now open it to debate. Mr. Vidal.
Not being a regular on this committee, I think it's important that we hear from the right people when we do things like this. And I would actually like to suggest an amendment that in that first hour we would include the Minister of Health to appear during the first hour of this meeting on November 15th.
Thank you, Mr. Vidal. So I understand now you're proposing an amendment for the first hour to include not only officials from Health Canada, but also the Minister of Health to appear during that first hour. So we now have an amendment on the floor. Is that correct, sir?
That is correct.
Thank you very much. So there's an amendment. We have multiple speakers. Mr. Van Couverden, and after that, Michel Champ. Mr. Van Couverden, you have the floor.
Thank you, Mr. Chair. I appreciate this was distributed in advance, and Ms. Goodridge approached our side before the meeting started. We had lots of advance notice. We're supportive of the motion, but I don't believe the amendment, we haven't had an opportunity to discuss that or anything, so we would be in favor of having, like you said, officials and witnesses from each, but we'll pass on having the minister at this time. We haven't had an opportunity to discuss it at all.
Thank you, Mr. Van Couverden. Michel Champoux.
Mr. Champoux, Mr. Chairman, it's dealing with the motion. It's not on the motion, the amendment. I wanted to propose that the committee free the witnesses unless we really have the intention of having another round of questions. And then we could discuss or debate the motion and then move to a vote. That might be more polite. Thank Thank you.
Good. Certainly, as you mentioned, that's really not about the amendment, but if I could poll the room and understand that the witnesses may be free to go. I see concurrence here. So I'd like to thank both of you witnesses for appearing here today. I appreciate your insights and how smoothly everything went and your understanding with the new sheriff and the 1-minute sign. So I appreciate that and wish you well today. Thank you very much for appearing.
Thank you.
Thank you.
Okay, merci beaucoup.
Thank you very much.
Have the floor.
Thank you, Mr. Chair. And I guess to Mr. Vancouverton, when I prepared the motion, I hadn't really, I'm still a relatively new member of Parliament, having been elected in the class of 2021. That wasn't something that I was initially contemplating, but I do take the suggestion from my colleague, Mr. Vidal. I think it's important to, whenever possible, this is an issue that parents from coast to coast to coast are really struggling with, and making sure that we have all of the answers as to what's causing it and what is being done to solve this, I think it would be beneficial to parents and would help alleviate some stress. And one of the things we heard from Ms. Degout is that children's mental health is a family issue, and I would suggest that a lot of families right now are facing a lot of additional anxiety because they are unable to find basic over-the-counter pain medication in a first world country. This is something that is standard in a country like, in a third world country. This is not something that's relatively standard in Canada. And so I think that it is worth merit and worth discussing. And I would hope that members of this committee accept that I am still a new member of Parliament, and I think this is a very good suggestion.
Thank you, Ms. Goodridge. Dr. Hanley, you have the floor.
Thank you, and I appreciate Ms. Goodridge bringing the issue to our to consider for a committee. I think this is important, and I think that the timing would be optimal. I think, however, I disagree with including the minister. I think really we want to get to sort out the story from Health Canada's officials' point of view. I wouldn't support the amendment, but I certainly support us having a one meeting on this important issue. Thanks.
Mr. Johari.
So definitely in support of the amendment. Thank you very much. It was distributed. We had the conversation. We were full support. And two things. Number one, 17 in such short notice to be able to get the minister. Number two is the minister, I'm sure sub B and the department results is going to be out very soon, within the next probably few weeks, I assume. And that's a great opportunity for us to be able to ask the minister in that session the questions that we want. By then, we have an understanding of what the department and what the witnesses are, and we also have data that we could ask, relevant and key questions from the minister. So definitely support the motion as presented by our colleague, Madam Goodridge, on the getting the minister here on a short notice on the 17th, without having heard all the other stuff. I will be opposing. Thank you.
Thank you, Mr. Johari. Mr. Champoux, s'il vous plaît.
Mr. Champoux. I'm hearing the proposed amendment by Mr. Vidal, my colleague, and if I may, I'll propose, if the Conservatives really want the minister to be part of this meeting of the committee, to delay the meeting by some time on this particular subject and move on to the study that was proposed by my colleague, Mr. Thériault, to study the issue that issue that's also very important for Canadians and for Quebecers. So I propose to change the date. So there are two meetings planned on my colleague's proposed study, and perhaps my colleagues, Liberal colleagues, would then agree.
So if I'm hearing you correctly, you haven't proposed an exact date, but the sub-amendment would be to delay the meeting and have the minister appear at a time in the future on this particular subject.
Monsieur le Président.
Mr. Chairman?
So, always interesting to be here at Health Committee. I've been informed by the clerk that any sub-amendment should really be directed towards the actual original amendment as opposed to sub-amending the sub-amendment. I don't know how that translated into French.
Difficilement.
That being said,
That was difficult.
Michel Chapeau, s'il vous plaît.
Je préciserais que c'était plus une...
I would specify that it was more of a friendly amendment that I was trying to table rather than an official sub-amendment.
Okay, thank you very much for that. Mr. Van Couverden.
Thank you, Mr. Chair. Always a battle with the little speak button. Again, I would just clarify that we're supportive of having a meeting in short order. I think it's important. C'est une rencontre d'urgence, je pense.
I think this is an emergency situation.
A good day to have it on. I would reiterate that I think getting to the bottom of it will, we should hear from our communities. As I've talked to Ms. Goodrich offline about this, I've called 5 or 6 pharmacies in my riding to check in. I think hearing from some pharmacists or from community, some experts in the country would be really, really helpful, and officials certainly as well. Just one other thing, point of clarification, something struck a nerve a little bit. The term third world is outdated. It's a Cold War era term that we don't use anymore. It can be derogatory in some cases, and comparing Canada to developing world doesn't do too much to highlight our challenges. We've got some, but the ones in developing nations are different. Thanks.
Mr. Davies, please.
Thank you. Well, with the amendments and sub-amendments, it was starting to remind me that the old adage that an elephant was designed by a committee. I think we got to get right back to the simplicity of this. I like the motion as it's drafted originally. I think calling the minister unnecessarily politicizes an issue and probably won't add any more substantive information than we'll get from the health officials. I do think that we do have a practical issue, which is getting the witnesses. We would have to have the witnesses proposed in, I would say, by the end of tomorrow, as a matter of function, in order to give the clerk next week an opportunity to have the witnesses, because it's the Monday when we come back. Tuesday, pardon me. That's more a question of administration, but I would support the motion as drafted by Ms. Goodrich for the 15th as written. I also think that if this is an urgent matter, then delaying it seems counterintuitive to the urgency. It also gives us a chance more to maybe even discuss among ourselves what witnesses we may want to have. It's my understanding that the shortage of children's pain medication is a global matter. That I'm not sure I can say every country, but I think almost every country is experiencing this. Second, I want to talk to industry a little bit. I happened to have a meeting this morning with the Canadian pharmaceutical manufacturer, in fact, the largest domestic manufacturer of pharmaceuticals in the country. And he had some interesting information about this as well. So it'd be nice to have a broad array of witnesses in that second hour so that we can get a fulsome picture to find out, what are the potential solutions for this. And that's where I'll conclude is my interest in this matter is understanding what the problem is, but more importantly, seeing what solutions may exist, not politically attacking the government on this, but rather working proactively to see what we can do to help.
Thank you, Mr. Davies. Ms. Sidhu.
Thank you, Mr. Chair, and thank you, my colleague, Ms. Goodrich, to raising this issue. I agree with all colleagues because it's an important issue. Let's deal with it. So I don't favor an amendment or sub-amendment, but I'm favoring a motion. It is important. Let's have a meeting, as Mr. Davies said, urgent basis with the Health Canada and the witnesses, pharmacists, and then from your writing, and we all working collaboratively. Let's work collaboratively on the motion. Thank you. Thank you, Mr. Chair.
Thank you, Ms. Sidhu. Ms. Goodrich.
I think just to, and I'd appreciate I appreciate the support I've received from my colleagues on this issue. I think it's critically important. One anecdote I'd like to share, because I think it's important, is the number of particularly young moms that have reached out to me since yesterday when this was brought up in question period. And this isn't about politicizing this issue. They wrote to me and they said, like, thank you. I have thought that I was crazy. I have felt like I was alone in this. I have been struggling. I didn't realize that this was more than just my problem or my community's problem. And it really made them feel heard. And frankly, inviting the minister was not an attempt to further embarrass. It was simply to try and see what other political mechanisms do we possibly have. It is not about bringing politics into this. Frankly, I don't want to see politics in this issue. I want to see this issue fixed. I brought this to the committee more than a month ago, and arguably it's worse than it was when I brought it to the committee a month ago. I haven't personally seen any children's pain medication on the shelves in my Northern Alberta community since early this summer. This is something that's hugely concerning. We're 5 hours from a children's hospital. I really do think that this is something that needs to be studied. I believe that the amendment coming from my colleague, Mr. Vidal, was not an attempt to bring this in to further politicize the issue, but to further get to the bottom of this problem, to see what has happened, what is going to continue happening, and what other mechanisms do we have? Because I think we have been able to show that we have pretty much cross-party support on this, and Canadian families expect and deserve to see that there is forward movement on this. So I understand that many believe this is bringing politics in. This wasn't the intention, and this isn't the space that it's at. I would just urge everyone to just consider the idea of bringing the minister in, because I think parents would love to hear some of what he's done. It'll hopefully make things better.
Thank you, Ms. Goodridge. And at the current time, our speakers list has collapsed. So that would make it an appropriate time to vote on the proposed amendment put forward by Mr. Vidal, that in the first hour the Minister of Health would appear as a witness. Assuming that's clear to everyone. Excellent. So let's just do this by a show of hands. All those in favor of the proposed sub-amendment, please raise your right hand. Amendment. My apologies. The amendment from Mr. Vidal? That's correct. Just what I just said. That's it. Excellent. The actual amendment. There is really no sub-amendment. My apologies. And all those against? Good reminded. Excellent. So the amendment is defeated. So we'll return to a debate on the amendment as proposed. Yes, that's it too. Oh, tough crowd. Mr. Davies, you have the floor.
I just think it's an appropriate moment to make one observation, and that is, this is an opportunity to think of young parents, and Ms. Goodrich has been very passionate and I think effective in sharing her and brave in sharing her own experience. I think with her child that had pain from teething and couldn't get pain medication, and bringing up young parents across this country who can't get pain medication for their children. So I think it's appropriate to point out here, the policy symmetry between this issue and lack of dental care, because there are millions of children in this country and parents who go to bed every night with pain because they can't get access to dental care. And, whether you're a parent who's got a teething child and you can't get pain medication, or whether you're a parent with an adolescent child that's going to bed at night with the same pain because he can't get dental care, it's the same parental pain, it's the same frustration, and I think it's the same health need. So I just think it's an opportunity to remind all of us as parliamentarians about consistency, and I'm hoping that this can serve as maybe a good example for all of us around this table from all parties to work constructively to address this problem, not only for the temporary issue of pain medication, but also for the structural opportunity to fix the problem so that we make sure that all children get access to oral health care in this country.
Thank you, Mr. Davies. I see no more speakers. So is the will of the room on the, I've heard, certainly, I believe, that on the original motion, there seems to be concurrence around the table as distributed, that members would support that. Is that the will of the room as I see it? Excellent. Okay. So the motion is that the committee hold a meeting on Tuesday, November 15th to discuss the ongoing shortage of children pain medication, to include an hour of officials from Health Canada, and the second hour to include one witness from each political party represented on the committee. And I've been informed by the clerk that we'll have to have those witnesses in by end of day tomorrow. Okay.
4 p.m. Eastern Standard
4
Time?
p.m. Eastern Time. Mr. Davies.
Thank you, Mr. Chair. Having disposed of that, I mentioned this to the chair earlier that with respect to our report that we're working on healthcare human resources, I was just going to suggest that if we could, from the analysts, if they could produce for us sometime by the end of next week a clean copy of the report that has the changes in it that we've agreed to. Because we've gone through the text of the report and we've agreed, and to have maybe have those highlighted would be helpful, and then also to have maybe in a different highlight the portions of the report that we've parked. One thing that comes to my mind is the jurisdictional section at the beginning, paragraphs 3 to 7. We said we'd come back to, maybe in a different color, so that we're working from an updated copy of the report, and that would be helpful, I think, for all of us.
So I thank you for that, Mr. Davies. I did have the opportunity to speak to our analyst with that, and please provide your comments to the committee.
I suppose our comments are that we will try our very best. There are other resources to consider, including translation capacity. So that's something we'll have to check in with our colleagues on. My sense from having discussions prior to this is that end of next week is unlikely to be an achievable target date, but we can work with them to provide it as soon as possible in advance of future discussions.
Thank you very much. Ms. Goodridge.
Thank you, Mr. Chair. I believe the suggestion from Mr. Davies is actually going to be productive and fruitful for us going forward. So I would put forward a suggestion to the committee that we perhaps not return to studying, to reviewing this until such a time that the analysts are able to provide it, understanding that they've got a busy workload and a lot of other things on their plate, that perhaps if that ends up taking a couple weeks, I think that is a very reasonable suggestion. This is a study that's gone on in this committee for a long period of time, and I think that that's a reasonable way to make sure that we're going through this expeditiously.
Thank you very much. Mr. Van Couverden.
Mr. Chair, I would just say that I feel like if we're going to get into conversation about the report, we're usually in camera during that. So I don't think we've gotten to that point yet, but we usually go in camera when we're talking about these types of things. So usually we're like comfortable about talking about that in that context. I would also just urge that we need to get, or I think we should get collectively, that report out before Christmas. And now we've got like 3, maybe 4, maybe 5, who knows how many weeks before Christmas, and we've got a new day which is important to talk about this. We've got a child health study. We've got all these concurrent things, and if we don't, I don't know, maybe it's just me, the way I organize my time, I want to finish one thing before I move on to another, and I think we ought to get that committee report tabled. So I'm not suggesting, there aren't competing interests here, it's just a matter of time.
Thank you very much. And I'll make sure that the actual chair understands your comments and how this should go forward. Mr. Davies.
Well, thank you. Well, in terms of the being in camera, we're not actually talking about the content of the report. We're just talking about structure. So I think we're okay. But the thing is that we all have been keeping notes as we've gone through the report. So I have my own, as I'm sure all of us do, annotated copy of the report. So it doesn't mean we need to hold up continued assessment of the report. Frankly, we're on the recommendations and we have to continue to plow through the recommendations anyway. I'm just saying that it would be helpful to have that copy so that when we do finish the recommendations and come back to the parts of the text that are parked, we know where they are. And I'm happy. I hear the analysts. As soon as reasonably practicable is fine. That's good. And but I don't think that it should hold up our continued work through this report because, again, like the pain medication, the HR human resources issue has been called a crisis as well, and it also has urgency to it.
Thank you very much for that, Mr. Davies. Certainly, good old common sense may prevail in the end. So I think that our discussions have been fruitful, and I think that we've heard the will of the committee that if at all as soon as at all possible, then we'd like to have that updated copy with the multiple highlights as per Mr. Davies, if we could. Mr. Davies.
I move to adjourn.
Is the will of the committee to adjourn the meeting? Great. Mr. Hanley, Dr. Hanley.
Before we adjourn, much as I've missed the voice of Dr. Ellis around the table, I'd like to congratulate his chairmanship today. Easily one of the top 2 chairs I've worked with on this committee. Thank you.
And on that note, meeting adjourned.